Welcome to today's video, where we'll be exploring a fascinating anomaly of the urinary system, ureteral duplication. This condition, where someone is born with more than one ureter draining a single kidney, can range from being completely harmless to causing significant health problems. Join us as we delve into the details of ureteral duplication, covering its causes, how it affects the body, diagnosis, treatment, and more. So, what causes ureteral duplication? It all begins during embryonic development. Around the 4th to 6th week of gestation, the ureteric bud, which eventually forms the ureter, grows from the mesonephric duct. Ureteral duplication occurs when this ureteric bud splits prematurely, or when two separate ureteric buds arise from the mesonephric duct. The exact reason why this happens is not fully understood, but genetic factors are thought to play a role. While most cases appear sporadically, meaning they are not inherited, there are instances where ureteral duplication seems to run in families, suggesting a possible genetic predisposition. Environmental factors during pregnancy may also contribute to the development of this anomaly, but more research is needed to confirm this. Understanding the pathophysiology of ureteral duplication is crucial. The duplicated ureters can drain different portions of the kidney, or sometimes they both drain the entire kidney. Problems arise depending on where the duplicated ureters insert into the bladder or urinary tract. One common issue is ectopic insertion. This is when one of the ureters, usually the one draining the upper portion of the kidney, inserts at an abnormal location. This ectopic insertion can be in the bladder neck, urethra vagina in females, or even the vas deferens or seminal vesicle in males. These abnormal locations often lead to urinary incontinence, vesicoreteral reflux, where urine flows backward into the ureter and kidney, and an increased risk of urinary tract infections. Another potential problem is ureteral, which is a balloon-like swelling of the distal ureter as it enters the bladder. Ureteroceles can obstruct urine flow, leading to hydronephrosis, a swelling of the kidney due to urine backup, and kidney damage. Even without ectopic insertion or ureteroceal, duplicated ureters can sometimes be prone to obstruction or reflux due to their abnormal configuration. Ureteral duplication is a relatively common congenital anomaly of the urinary tract. Estimates suggest that it occurs in approximately 0% to 4% of the population. It's more frequently found in females than in males, and it's also more common in Caucasians. Bilateral ureteral duplication, meaning both kidneys are affected, occurs in about 15% to 20% of cases. It's important to remember that many individuals with ureteral duplication remain asymptomatic throughout their lives and are never diagnosed. The actual prevalence may therefore be higher than reported in studies that focus on symptomatic individuals. The signs and symptoms of ureteral duplication vary depending on the severity and location of the anomaly. Many people with duplicated ureters experience no symptoms at all. However, when symptoms do occur, they can include recurrent urinary tract infections, daytime or nighttime incontinence, particularly in children, flank pain or abdominal pain, fever, and painful urination. In some cases, an ectopic ureter may cause continuous dribbling of urine, even when the bladder is empty. In infants, ureteral duplication can present as failure to thrive or unexplained fever. It's important to note that these symptoms are not specific to ureteral duplication and can be caused by other urinary tract problems, making accurate diagnosis essential. Diagnosing ureteral duplication often involves a combination of imaging studies. Ultrasound is typically the first-line investigation as it's non-invasive and can detect hydronephrosis or other abnormalities suggestive of duplication. Voiding cystoarthrogram, or VCG, is a special type of X-ray used to visualize the bladder and urethra while the patient urinates. This is helpful in detecting vesicoreteral reflux. Intravenous pyelogram, or IVP, is an X-ray examination that uses a contrast dye to visualize the kidneys, ureters, and bladder. It can help identify duplicated ureters and their insertion points. CT scans and MRI scans provide more detailed anatomical information and are particularly useful in complex cases or when other imaging is inconclusive. Cystoscopy, where a small camera is inserted into the bladder, allows direct visualization of the ureteral orifices and can help identify ureteroceles or ectopic insertion sites. While there aren't strict classifications of ureteral duplication, it's helpful to understand the different ways it can present. We can differentiate between complete and incomplete duplication. Incomplete duplication. Each ureter drains a separate part of the kidney and has its own opening into the bladder. In incomplete duplication, the two ureters join together before entering the bladder, forming a Y-shaped structure. Another distinction is between unilateral and bilateral duplication, referring to whether one or both kidneys are affected. Furthermore, we consider the insertion point of the ureters, whether they insert normally into the bladder or ectopically into other locations. The presence or absence of complications, such as ureterocele or vesicureteral reflux, also plays a role in describing the type of ureteral duplication. Treatment for ureteral duplication depends on the presence and severity of symptoms, as well as the presence of complications. Asymptomatic individuals typically require no treatment, but regular monitoring may be recommended. For those experiencing recurrent urinary tract infections, antibiotic prophylaxis may be prescribed. Surgical intervention is often necessary for symptomatic cases or when complications such as vesicureteral reflux, ureterocele, or obstruction are present. Surgical options include ureteral reimplantation, where the duplicated ureters are repositioned to drain properly into the bladder. Ureterostomy involves joining the two ureters together before they enter the bladder. In severe cases where the upper portion of the kidney is non-functioning due to complications, a partial nephrectomy or removal of that portion of the kidney may be necessary. Endoscopic procedures, such as incision or marsupialization of a ureterocele, can also be performed to relieve obstruction. Unfortunately, there's no known way to completely prevent ureteral duplication, as it's a congenital anomaly that occurs during embryonic development. However, women planning to become pregnant can optimize their health by taking prenatal vitamins, avoiding smoking and alcohol consumption, and managing any underlying medical conditions. These steps can help reduce the risk of various birth defects, although they won't specifically prevent ureteral duplication. Early detection and management of urinary tract infections in children can help prevent complications associated with undiagnosed ureteral duplication. The prognosis for individuals with ureteral duplication is generally good, especially with early diagnosis and appropriate management. Many people with this condition live normal, healthy lives without significant problems. However, untreated or poorly managed complications such as recurrent urinary tract infections, vesicureteral reflux, and hydronephrosis can lead to kidney damage and, in rare cases, kidney failure. Recent research is focused on understanding the genetic factors involved in ureteral duplication and developing less invasive surgical techniques to correct the anomaly. Ongoing studies are also investigating the long-term outcomes of different treatment approaches to optimize patient care.